Let's get started. Just to review very quickly the objectives for this afternoon, I hope that you come away at the end of this with a better understanding about brain injury, the mechanisms, how it happens, what causes it, more importantly, the consequences of brain injury, and some takeaways where you feel better prepared to successfully interact with people with brain injury. As an acknowledgement of our funder, this project is supported through state general funds through the Virginia Department for Aging and Rehab Services. We thank them. So, brain injury. I used to call this the silent epidemic, and it's not so silent anymore because brain injury has been in the news more, both what our veterans are dealing with and returning from war, what's happening with the NFL, even more with high school and college sports. We see brain injury get talked about more than it, certainly more than it used to. But even with all that, brain injury is still the leading cause of death and disability in children and adults under the age of 45. Oops, sorry about that. Going the wrong way. When we talk about brain injury, we talk about acquired brain injury, not the brain injury that you're born with or that happens during birth, the birth process, but something that happens when a person is typically developing and then, bam, they acquire a brain injury. We classify it as traumatic and non-traumatic. Traumatic brain injury, which is where our organization started, was working with folks with traumatic brain injury, is defined as where the head is subject to an external force. And this is the definition that is used by the Department of Education in the school system. Furthermore, it's classified as open and closed head injuries, pretty self-explanatory. In open head injuries, the skull is crushed or compromised in some way. That includes gunshot wounds. It certainly makes the person more susceptible to infections, and that carries with it certain considerations. In closed head injuries, which fortunately are more common, the skull is subject, is not damaged, but the brain inside is subject to force, and that creates damage. Non-traumatic brain injury occurs from an internal source, most commonly stroke, but also these other instances that are listed there. I want to make special notice of hypoxic and anoxic brain injury. Hypoxia is where the brain has low levels of oxygen, and anoxia is where there's no oxygen going to the brain. And the thing about our brains is that they are oxygen hogs. It really needs oxygen in order to do its job, and it gets it through oxygenated blood. And so whatever it is that disrupts that flow of oxygen to our brain can cause injury. And it happens in a lot of different ways. It can happen traumatically, such as if a person almost drowns or is electrocuted and stops breathing. It can happen non-traumatically, from the medical sense, in the instance of, let's say, a heart attack, and then the heart stops pumping blood and then the brain suffers. So it can occur in a lot of different circumstances. When we talk about the causes of traumatic brain injury, it can vary by age. Falls happen most commonly to the very young and to the elderly. Motor vehicle accidents happen to most often to adults, particularly young adults. Once upon a time, motor vehicle accidents were more common than falls, but our population has gotten older, and our safety in cars has gotten better. A lot more things that protect us in cars, so we see that shift. What hasn't changed is the frequency in which alcohol is a factor in traumatic brain injury. It's a pretty wide range, 37 to 51%, but it has to do, probably a lot to do, with the poor judgments that one might make when you're under the influence of alcohol. We talk about the incidence and prevalence to have a grasp of just how many people are we talking about here. Well, the CDC, the Center for Disease Control and Injury Prevention, does accumulate data on how often it happens. These numbers that are here are national numbers. So 1.1 million treated and released from emergency departments, etc. What is not seen here are the people who never go to the emergency room, who may only seek assistance from urgent care centers or their private doctors. Those numbers are not counted. And so we know that there are far more people than this. But looking at these statistics and adjusting for population in Virginia and the rate of prevalence, we estimate that about 170,000 Virginians are living with long-term disability as a result of TBI, traumatic brain injury. Now, for those of you who know how hard it is to get long-term disability, you know that there's far more people than that whose lives and abilities have been affected by brain injury, but they may not have that classification. When we look at stroke numbers, we also have numbers of prevalence, and we look at about 75,000 Virginians who are disabled as a result of stroke living in the community, not counting the people who are in institutions. So combining just those two numbers of TBI and stroke, we're looking at about 245,000 people in Virginia with some sort of brain injury. And we know that number is really an underestimate. Some of those people, I'm going to estimate, if you're a professional working in any sort of human services field, they found their way onto your caseload. So I want you to think about a few of these points. We know that domestic violence is really underreported, and but it's estimated about 2 million injuries every year. We also know statistics about intimate partner violence, that 50 to 90% of those assaults affect the head, face, or involve strangulation or choking. So we're adding even more people to the roles of possible folks living with the effects of brain injury. We know that those living with brain injury are going to have higher suicidal ideation and higher attempts and completed suicide, so there's mental health services. We know that the rate of head injury among people who are homeless are far, far, far greater than that in the general population. And when we see later on what those effects of the brain injury are, it's not surprising that people might end up homeless when they're dealing with so many challenges. And then when we're looking at whether incarcerated adults or children who are in the Department of Juvenile Justice, both of those populations have seen high numbers of brain injuries in their past. So my go-to statement is that if you're working in human services, you have folks with brain injury on your caseload, whether you know it or not. One of the things that have happened in the past 30 years, because, yeah, I've been in the field that long, but one of the things that I've seen happen is the change in perspective, that brain injury is not just an event that you get through and get over and move on, but it is really the beginning of a disease process. It's a chronic condition. And as we think about it as a chronic condition, then we want to try and help those people who have that chronic condition live better with it. If you are susceptible or predisposed because of your genetic makeup to Alzheimer's or mental illness or several other illnesses, you are more likely to develop that earlier if you've had a brain injury. Once you survive your first year of a brain injury, your lifespan is still shorter than someone who never had a brain injury. And quality of life certainly changes as well. So this really is a shift, a paradigm shift as they call it, looking at it more of a chronic condition than just a get over it and move along. So let's talk about your brain, that wonderful motherboard contained between our ears. Many of you may have seen pictures of the brain before. Everybody's brain is different, certainly, but this is a general scheme about the different lobes that are contained there and their different jobs. So when you look at a brain like this and you see that different areas of the brain have different jobs, you know that where a brain injury happens will affect the consequences for any one particular individual. Some functions of the brain are very basic. What happens in the brain stem and the cerebellum, we don't even think about these things. The brain stem, keeps your heart rate and your blood pressure good, and your level of alertness. And the cerebellum has to do with posture and keeping yourself upright and having the right amount of muscle tone. But more deliberate thinking happens in these higher lobes here. The lobe that develops last as we enter our early 20s is the frontal lobe. And it is what differentiates adults from adolescents, I think, because of these functions: the ability to control your emotions, to manage your impulses. Don't do or say the first thing that pops into your mind. Teenagers struggle with that. Some adults struggle with that, but still, that is a function of the frontal lobe, which also, unfortunately, corresponds to one of the lobes that is most frequently injured when you have a traumatic injury because of location. In addition to the lobes being part of what controlling function, we also have the hemispheres. The right hemisphere and the left hemisphere of our brains function differently. The left side of our brain, which controls the right side of our body, is associated with verbal, logical, and analytical thinking. The right side of our brain, which controls the left side of our body, is associated more with creativity, the big picture, the things you know intuitively. And both of those merge together to, create a well-balanced, well-functioning person. But certainly if one side of the brain, again, versus the other side of the brain is affected, that's going to be demonstrated in the sort of deficits that the individual is living with. So we're going to talk a little bit about anatomy. Certainly not all the attention that something as complex as our brains deserve, but I'll give it a shot as a non-medical person. Our brain has the consistency of gelatin, well-done gelatin, overcooked oatmeal. I've heard both of those comparisons. It weighs in at about 2 pounds as an infant and grows to 3 pounds as an adult. Neurons are the cells that make up the nervous system, or at least the ones we're going to be talking about today. Neurons are the workhorses of our brains, and they help pass messages to each other using a special type of electrical signal. Some of these signals bring information from outside of the body, inside, such as the things that you see and hear and smell. Other signals are instructions for your organs, your glands, your muscles, or even from our thoughts. What is it that we're thinking? Has to happen through neural transmission also, and how we're feeling, our emotions. So very briefly, what we see here on this end, I hope my pointer is noticeable, on this end is the dendrite. So this is where the messages get taken up. Neurotransmitters get taken up here, travel through the body of the cell, down the axon, which is protected by myelin sheaths, and then out these terminals. And of course, in the time that it took me to say this, well, I don't have an exact time of how quickly this happens, but let's say it's very, very fast. And so that's what happens in the normal mode and the way it should happen. Let's look at when the brain gets hurt. And I'm starting with traumatic brain injury. It's probably the more complicated type of injury. there's a number of mechanisms that are at work. One is the force. When your hard skull hits a hard object, a fall, a blunt force trauma, hitting a windshield wiper, a windshield, it can lead to bleeding inside the brain, swelling, and increase of intracranial pressure. That brain is normally bathed in intracranial fluid, has fluid, but it increases and kind of escapes where it's supposed to be once there is impact. So that can increase pressure, and our brains are contained inside this nice little compact skull of ours, so that can deform the tissue. The other thing that happens as well is that, you know, the outside of our skulls are pretty smooth, but not so much the inside of our skulls. There's more sharp edges or ragged edges that can irritate the brain when it hits across that. So that also contributes to the bleeding that can happen. Then we also have very violent motion of that head, even if there's not physical contact with a hard surface. So in the instance of whiplash, for instance, or when someone is shaken, there can be damage that happens just by that violent movement. That those brain cells that I showed you earlier are really a very delicate web of cells, and when that gets disrupted because of the impulse loading, there can be tearing of that network, and the cells, the neurons themselves, are damaged. Then as a result of that damage that happens to the cells, there is a secondary injury, or which is the neurochemical cascade. There's an influx of neurochemicals that can overstimulate brain cells and subdue them. So we have cellular death and things inside and outside of the cells where they don't belong. So overall, you have cellular damage. This can be why oftentimes CAT scans may be negative. Actually, in 45% of the time, CAT scans don't show damage, because the only thing that CAT scans show is if there is this part, if there is severe bleeding in the brain. What it does not show is when there's cellular changes. That can't be captured, and it can attribute to the problems that we see. This is how the brain is hurt with a stroke. As I said earlier, the brain is an oxygen hog. It needs oxygen in order to do its job. And oxygenated blood coming from our heart is how it gets that oxygen. When that blood flow is disrupted in one of two ways, either through hemorrhage or ischemia, everything that is downstream from that event is going without oxygen. In a hemorrhagic stroke, as what you might see when the blood vessel bursts, such as in an aneurysm, there is an excess of blood then outside of the blood vessels, and they can be harming the brain cells. In an ischemic stroke, as what's seen in a blood clot or a narrowing of the arteries, you have a blockage of the blood flow. And it makes sense that the further downstream it is, the smaller the area that is affected. But that's the mechanism of stroke. You might have heard, brain injury, strokes being called a brain attack, and that is because it's a very similar mechanism to what happens to in our hearts. One of the pressing questions for just about every doctor and team who has worked with people with brain injury is, what will the outcome be? What will happen to our loved one or the patient? And that is a very difficult thing to predict because there's a lot of variables. As you can see, the cause of brain injury, when you look back at what happens in the mechanism, that can affect what challenges a person will deal with. The location, when we looked at those lobes of the brain, certainly happening in one lobe versus another lobe, or one hemisphere versus another hemisphere, will dictate the specific challenges that the person is having. Severity of damage, which we're going to talk about next, and the type of treatment both affect those specific challenges too. But long-term recovery is also affected by a whole host of other things, including, what was the person like before their injury? What brain did they bring with them when they were injured? Age is a factor. Certainly, to a certain extent, the younger you are, the more you may have success in recovering. But, conventional wisdom used to say that children who were injured were not, children were so resilient, and children just didn't get affected by brain injuries as much. And that's not really totally fully true, because the truth is that because their brains are still developing, children who are injured, the immediate impact of that injury is not seen right away until they fail to achieve certain developmental milestones. We don't expect a 4-year-old and a 14-year-old to behave the same way. You expect that by the time they get to 14, they've learned a few things, and they have. But that can be challenged if they are injured young. Additionally, if the brain injury happens a long time ago, people sort of forget about it. So we might start looking at other labels that a child might get assigned to them, like they're oppositional, or they have ADD, or any number of other labels that might be put on them. So that's an important thing to remember. I always tell when I'm talking to parents who call our office that even if they're not seeing problems now, to keep this as part of the medical record of their child, and to be mindful of how that child is progressing through developmental milestones. So that's just an aside. So there's a lot of things that can affect long-term recovery, and certainly family involvement is a very key thing to that as well. So let's talk about the severity of brain injury. And again, I'm sticking with traumatic brain injury right now. Mild TBI, which is really what a concussion is a type of mild traumatic brain injury. Fortunately, accounts for most brain injuries, 75 to 85%. There may or may not be a loss of consciousness. If there is a loss of consciousness, it's relatively brief, less than 30 minutes. And periods of confusion and memory loss don't last for more than a day generally. These are the type of injuries that are most likely to be overlooked or misdiagnosed or undiagnosed. Unless the person has some sort of accompanying injury, they're usually not hospitalized. And they may experience problems for a couple of months before they recover. Fortunately, most people do recover. But there is a subset, about 15% of people who will have ongoing chronic problems, behavioral problems, emotional or physical problems as a result of even a mild brain injury. Certainly one of the things that we know is that if you've had previous injuries, even if they've been previous mild injuries, that cumulative effect can make it harder to bounce back from newer injuries. In addition, if you've had a brain injury, you're 3 times more likely to have a second brain injury. And if you've had 2 brain injuries, you're about 8 times more likely to have a third. So, my advice is try to avoid one at all costs, at all possible. Then we talk about moderate and severe injuries. And I put these together because these are the type of injuries more likely to be where the individual is going to be hospitalized. They're unconscious longer. They are confused and disoriented longer and have memory loss for before and after the event. They are going to be probably, like I said, more typically diagnosed and receive follow-up care. Now, even though they may be diagnosed and receive follow-up care, whether or not that is adequate care, adequate rehabilitation, and to the extent and the intensity and the length of time that that is needed is very variable depending on what your health insurance is. And that will have a great impact as far as the type of outcome a person has. If they don't get adequate rehab, they may have much further reaching deficits that they have to deal with. So it's a long road to recovery, and I think most people start off thinking that they're going to just get better from their brain injury, they're going to go back to normal. In the brain injury field, we talk about a new normal, where success gets really redefined, and that is redefining what the problem is. So rather than it being something that you have to overcome and go back to the way you were the day before your accident, it really has, success has more to do with understanding that lifestyle changes, oops, sorry, lifestyle, this is what happens when you talk with your hands, that lifestyle changes are necessary, just like dealing with any other chronic condition. And that the better you understand your strengths and weaknesses, the better you can function. Also to consider that, like in many chronic conditions, a person may need to re-enter therapy from time to time. That might be traditional therapies like PT, OT, and speech, or it may be psychological, neuropsychological sort of treatments. So I bring up some things for you to consider, because these can sometimes be stumbling blocks for people with brain injury. Many times when you have an individual who's had a brain injury, they are a combination of strengths and weaknesses, as I said earlier. So there can be pockets of ability that are living right alongside areas of dysfunction. But sometimes that very thing is interpreted by well-intending professionals as, oh, that person's trying to be manipulative. They can really do more than they can. And that's a pitfall you really want to avoid. Alongside with that is that the awareness of what any one person has, what their difficulties are that are caused by brain injury, are oftentimes not immediately apparent to that person. It is a very function of brain injury that you may not recognize the very deficits that you're dealing with. So if you are a professional working with a person with a brain injury, the better that you can understand what their cognitive status is, the better that you can help them to adapt to the situation before them. A very helpful tool with that, when at all possible to obtain, is a neuropsychological evaluation. That is a comprehensive assessment that is done by a specially trained psychologist that looks at how a person functions cognitively, behaviorally. They use standardized tests, but they, take into consideration a person's educational background and life experiences. So if that is at all possible, that can help you to team up better with the individual that you're working with. So let's look at some of those problems. And I'm not going to read these to you because you're perfectly capable of reading these things, but I do want to point out on the next couple of slides some problems that stand out. Fatigue and sleep disturbances are probably, particularly fatigue, are probably one of the most common problems seen physically after a brain injury. Sleep disturbances slightly different than that, but certainly can exacerbate fatigue. And people might have difficulty sleeping, or they find that they sleep excessively. And of course, both of those can interrupt your function in a number of ways. And then we see a couple of other physical and sensory problems. People, don't recognize, this is a hard thing to see when people have, when a person has changes in their vision, hearing, smell, or taste. You can't see those changes. Well, and as is true for the rest of the problems that we're going to talk about, most of them are not immediately apparent to someone looking at the individual. When we look at the common cognitive changes, probably memory, Short-term memory is the most common problem. The short-term memory that tells us, did I eat breakfast this morning? Do I have a doctor's appointment this afternoon? Did I tell my mother about that visit that I went on, or any number of things? We take a lot of these things for granted when they are working, but when they don't work, it really leads to a domino effect of difficulties. The emotional changes that happen, you can see here, depression and anxiety are probably the most common ones, again, that we see. Depression, many times people write off going, well, sure, someone would be depressed. If you were going through so many losses, you would be depressed. And certainly that's true. Having to deal with all the losses and the subsequent changes that occur from those losses can certainly make a person depressed, but it's also being recognized that there are those biochemical changes that can occur that can exacerbate, worsen that depression. Anxiety is also very commonly seen. If we think about the change in those cognitive functions, you can't remember as well, you can't organize yourself as well, you may not have access to all those ways that you coped with before. So yeah, you're going to feel a little anxious about that, and you're feeling much less confident, so that generally raises a person's anxiety as well. So, and then we see things like, quickly shifting emotional states where they seem fine one moment and then the next minute they're crying or angry or tearful. Low self-esteem and difficulty managing anger or some of these other emotional changes that we might see. Behavioral challenges, how a person acts, changes as well. When we see behavioral challenges, this is what is usually most disturbing to families and friends. We are under the impression, I think, as humans, that, I am what I am and that's what I am. And once I'm an adult, my personality is pretty well set. But that's not necessarily true because, if you think about it, our personalities are very much a complex interaction of what our brain functions are. Think for a minute of somebody that you respect, and think about their traits. So you might say, well, so-and-so has a good good sense of humor, or they can always see the big picture, or they are they're a good listener. Well, these are all functions of our brain, and when that changes, people's behavior changes, and they find that their social world might really diminish incredibly, and that creates a whole nother stressor. So behavior challenges is one of those big changes that have a domino effect. But when we talk about behavior changes, when we have a list like what I just showed you, that's sort of abstract. So what do we see when you're talking with somebody? So these are some of the things that you might recognize in maybe some of your clients. Maybe having a hard time identifying problems and generating solutions. If you can't come up with a plan of action, that might be because of memory problems or attention problems or organization. The behaviors you see can be linked to a lot of reasons behind them. I was talking with a lady, one of our I&R calls, and she called us wanting to get involved with counseling. She even knew where she wanted to get it. She just needed the phone number. Well, I gave her the phone number, made some suggestions on how to present, and called her back about a week later. Hadn't made the phone call because she kept on getting distracted by other things going on in her environment. So we talked about some ways that she could make this a priority, like right after our phone call, why don't you make this phone call right now and set up an appointment? Called her back a week later, still hadn't done it. These are, you know, she has all good intentions. I'm not quite sure when she'll make that appointment, but she knows she wants to. But this can happen frequently. You might see in your on your caseload people who miss appointments. That can be a function of memory or organization as well. So it's helpful to see what is behind the behaviors that might make it difficult for you. When we look at some of these communication and behavioral challenges, you can see that, you know, sometimes the person with the brain injury is maybe the person you think of being tough to work with. And that's okay, you know, but what we want to do is give you some ideas so you can help support that person and help them to accomplish what they're working with you to accomplish. You might see, you know, sometimes a person might seem argumentative or stubborn. Well, it might be an issue that maybe they're perseverating a little bit more than they should. Perseveration is that difficulty to let something go. You've said it and now you're going to move on. The person who perseverates kind of gets stuck on an issue and can't let it go. This is, you might have someone who doesn't realize that you're talking about one thing and they're talking about something else, and they haven't recognized that there's been a breakdown in communication. So that's where it's helpful for you to recognize that there's been a breakdown in communication, and they may not be arguing with you, but you're not on the same page. If someone is not aware of the need for supports or accommodations, they might really resent that you're trying to give them supports or accommodations. So these are a few challenges that you might see as you're working with individuals with brain injury. I put this slide up because I think it's a really good illustration of what can happen for folks with brain injury who are termed as having a quote-unquote behavioral problem. Now, this list of challenges can be anything that comes off of those 4 or 5 slides that I had that talk about all those difficulties that a person might have. They might have headaches, they might have pain, they might have attention or focus problems, any one of these issues here. But basically what you're having here is that there is a lot that is draining that person's cognitive reserve. The more they have to deal with, the less they can maybe think things out or maintain a calm. So they're dealing with all of these things and they become overwhelmed and fatigued and maybe defensive. And as a result of getting defensive, they want to defend themselves. They might see actions by others as threats, and then they react with them with frustration, anger, and aggression. One of the tenets of behavioral, helping people with behavioral problems is recognizing how often behavior is communication. And if a person is venting and becoming angry and aggressive, they may be communicating all sorts of things to you, perhaps not in the most appropriate way, though. So I put this up here to remind everyone that just how these behavioral problems can progress. So let's look at some ways that might help your interactions be more beneficial for everyone involved, you and your client. Excuse me. So one thing is to try to keep communications simple and clear. Just don't say things, but try to help make sure that that person understands. Now, I think it's very important to really form a partnership with the person that you're talking with who has a brain injury, or that person that you're working with. And to name that elephant that's in the room. If you are, I'll give you an example. if you're talking with somebody and you find, for instance, that they go off on tangents. Now, that happens, and that can get very frustrating because you're trying to make a point and they're going all over the place. If you enter into a partnership with that person, you might stop them at some point and say, you know, hold on, you know, we've been talking for a while and we've kind of gotten all over the place. Can I give you some feedback, please? And I'll tell you, a lot of times people go, yeah, okay, fine. Well, I've noticed that, you know, we started talking about one thing and then we talked about a whole lot of others. So if it is okay with you, if I see you doing that, I'd like to give you that feedback so we can stay on topic and talk about what you called me for. And that has worked very well. People are usually pretty grateful to get that feedback if it's done in a respectful way and takes into consideration that they might have some awareness of this as well. So, you know, that's just an example of trying to communicate clearly, enlist their feedback, ask them about what, you know, giving them information, I think one little bit at a time, and really engaging that person in trying to get a more productive interaction. A few other ideas of working better with people with brain injury, and one of them is compensatory strategies. Now, compensatory strategies are basically using deliberate, consistent procedure, carefully designed, to help a person accomplish a task. Sometimes a difficult task, sometimes a not so difficult task. It utilizes the skills that are intact for a person to help them be more consistent and more independent in accomplishing something. It can be used for any number of things: activities of daily living, attention, memory, behavior. As I said, it puts into place a structure of how to accomplish something, and it relies on consistency and repetition. May involve managing the environment, and again, persistence. You have to practice it. Like any other skill that comes along, it needs to be practiced. Now, examples of compensatory strategies are very, you know, there's a lot of examples that are out there. One place to start is with that person themselves. What have they found works? Or what have they already been taught that might need some reinforcement? If they are writing things down already, that's great. But let's write everything down in one place so you don't have, you know, 100 sticky notes that are competing and you can't really find anything that you need. So, you know, you want to work hand in hand with that person. Some low-tech examples are memory book, checklists, to-do lists. Perhaps they need some adaptive equipment. High-tech examples can be phone apps, pill reminders, personal emergency response system. When you're devising and you're working with a person on if they don't already have compensatory strategies worked out from a brain injury provider, you might want to keep in mind how comfortable a person is with, you know, what's their technology savvy. Someone who doesn't have a smartphone is not going to be real prone to wanting to use phone apps. They might be more comfortable with pen and paper. If you are working with multiple, if the individual with brain injury is working with you and others, it is good for everyone who's working with that person to have a consistent approach. If you as their counselor is using one approach and their vocational counselor is using something else, that's going to be conflicting. And so that consistency and that ability to practice in different settings can be very, very helpful. But it takes open communication in order to do that. And so as much as you can engage that, that's a good thing. You know, some settings, such as schools, have that set up a whole lot more easy to come by. You know, if you're a teacher that's working with several other teachers, you know, on different subject matter around a student, it is easier to make sure that, let's say, all the teachers and the mom and dad at home are all using the same strategies. That's going to reinforce learning and result in being more successful. So some ideas at work. You know, we talk about managing the environment. That's another way of helping that person to adapt. Be aware of how sensitive, for instance, is this person to auditory stimulation. You know, some folks with brain injury might be really sensitive to noise, or really sensitive to something as simple as overhead lights, like that you see with you know, fluorescent lights that have that little bit of stimulation in them. Some people are very sensitive to that. Again, for instance, if you're working in a school system, you might put a student in the front of the classroom so that they have less things in their visual field. You might help, let's say, if you're working with someone vocational, you might help them to organize their work area. As that individual permits, educating others around them can also be helpful so that they don't overreact to something, or they might help that person to reinforce a strategy that you're trying to teach them. As you can see, structure, consistency, repetition is just key, because people with brain injury can learn, definitely, but it might take a whole lot more repetition than they needed prior to their injury. Maintaining calm interactions is really a good, is an important way of setting the tone. If you are hyped up and extremely sensitive and take something personally and get defensive, that's going to make it harder for that person to interact with you. And so don't take it personally, which I know is easier said than done, but believe me, it really makes a difference in the long run. So I don't know, Deborah, how we're doing with time. I think I've covered everything that we set out to cover. I hope I didn't speed through things too much. We reviewed how the brain is hurt, common consequences to brain injury, and some ideas, certainly not all the ideas we could come up with, but some ideas for working more successfully with brain injury. So think about what questions you have, and please submit them to Deborah. While you're doing that, I'm going to show you two more slides just for your information, really for your reference. The Brain Injury Association of Virginia is here to help you with your clients. So you can refer the folks that you're working with directly to us, or you can consult with us if you want to problem solve some ideas with us. We have names of professionals familiar with brain injury programs that work with people with brain injury, and we have a very large clearinghouse of material to help people better understand brain injury. And that's geared towards professionals and family members and folks with brain injury. I think all of those folks need to be educated. We can connect you to a statewide network of support groups. We have educational events such as this and our annual conference, which is coming up in March, by the way. Camp Bruce McCoy is an annual spring camp for adults with brain injury, and we do advocacy to try and help the system become more responsive to the needs of people with brain injury. So that's just a few things that Brain Injury Association does. And I have here listed for you some ways of learning more about brain injury. If you are a teacher, I will bring certain, I'm just going to do a little plug for us again, on the BIAV website. You will find under learning about brain injury, and I think it is listed with children brain injury, it is our educator's guide to brain injury, and that can be a great resource for educators. So I'll stop talking, and Deborah, do you have any questions?
We do not have any questions at this time, so thank you, Christine. If you do have a question, I just posted my email address and Christine's email address if you have something later, and there's her email address. If you want to get in touch with us or if you have future questions, and just a reminder once again, if you need a copy of this PowerPoint or the professional's guide, you can download those to the right now if you haven't done so already. I'm going to keep it live so you can do that. So I'm going to wait a couple minutes to allow people to do that. And I don't see any questions. We're going to stay open for another minute or two. Otherwise, thank you so much for joining us and have a good afternoon.